All right, good morning, everybody. We'll get started. Welcome back to the Department of Medicine's Grand Rounds. My name is Stephanie Socias. I'm one of the chief residents this year. And on behalf of Dr. Frazier and the rest of the department, the chiefs, we'd like to welcome you back to Grand Rounds and thank you all for joining us, both here in person and on Zoom. This year, Grand Rounds is going to continue as a hybrid series of talks. So most sessions will have both in-person and Zoom options, but make sure to head over to the Department of Medicine's website for the most timely updates on modalities. So over the next 4 weeks, we have a special series of talks in which we highlight the work of some of our third-year internal medicine residents. We will hear from 2 residents each week. And today we're going to start off with Neha Akkad and Margery who I will introduce individually before each talk. And then if you could please hold your questions until the conclusion of both talks, and we'll have plenty of time then. So first up, we have Dr. Neha Akkad. She is originally from Framingham, Massachusetts, completed her undergraduate studies in biology at New York University before heading out to UCLA for medical school. She's now completing her internal medicine residency here at WashU, where she's also part of the C-STAR pathway. But she has already distinguished herself in the Hem-Onc world, having won multiple awards and grants, including a Young Investigator Award from the Society of Hematologic Oncology and a Catalyst Research Grant from the Cutaneous Lymphoma Foundation. She is currently applying to Hem-Onc Fellowship with plans to specialize in lymphoma. So please welcome Dr. Neha Akkad.
Hey, good morning, everyone. Thanks, Stephanie. For people that I haven't met, I'm Neha. I'm a third-year resident, interested in Hem-Onc and especially lymphoma. So I'm excited to talk to you guys about a topic I'm really interested in, which is cutaneous T-cell lymphoma and quality of life. I have no conflicts. So what I hope you get out of this talk is how to identify the presentation of cutaneous lymphoma or CTCL versus other skin diseases. What is the approach to diagnosis and treatment, and why is quality of life so important in this patient population? So what is cutaneous T-cell lymphoma? It's possible that a lot of you have not thought about this since medical school, so let's go ahead and define it. Broadly, this is a heterogeneous group of monoclonal T-cell proliferations of the skin, with the 2 most common subtypes being MF or mycosis fungoides and Sézary syndrome or SS. MF is more of the mature T-cell lymphoma that presents in the skin, the lymph nodes, the blood, and the viscera. SS is Sézary syndrome, the more rare leukemic subtype, and that presents as erythroderma and has malignant involvement of leukemic T-cells. CTCL is pretty rare. T-cell lymphomas in and of themselves make up about 10 to 15% of non-Hodgkin's lymphomas, and cutaneous lymphoma is an even smaller subset of T-cell lymphomas. Incidence is about 2,000 and prevalence is about 20,000. So how does this present? MF presents mainly as skin involvement. So these patients will probably more so present to a dermatologist, and they'll present with having a rash. And they might have a rash that's disproportionately pruritic. So it's more itchy than a rash that you would normally think of. And we'll kind of talk about details as we go along, but MF can present with patches, plaques, tumors, skin color changes. So let's go through a couple of examples. Can I use this? Yeah. So here's an example of a patch at the top. Patches are kind of flatter. You can see that they can be any shape, size, color. They can be really itchy. At the bottom here is an example of a plaque. A plaque is a little bit more 3D, a little bit more textured. You can say it has like a wrinkled cigarette paper-like look to it. CTCL is also pretty hard to diagnose, partially because it's heterogeneous. So I'll show you a few more examples, but they all look really different, so they can be hard to identify. They also can wax and wane, and some people have waxing and waning lesions really the whole time they have cutaneous lymphoma. It's also really rare, so it just might not be something that you necessarily think of. Here are a few more examples of how it can present. So on this side, you can see a few examples of the tumors. The tumors have to be greater than 1 centimeter by definition, and you can see that they're a little bit more 3-dimensional, they're a little bit more nodular. Here at the top, you can see an example of a hypopigmented plaque. Another thing to note here is that in patients with different skin tones, these can present quite differently. The bottom here is an example of a patient that has patches, plaques, and tumors, And I point that out to mention that people can have non-uniform lesions. So all of their lesions can look a little bit different, like this patient here. And here's a few more examples, again, patches, plaques, tumors. And what I'm trying to point out is that they all look really different. So they're really heterogeneous in the way they present. Sézary syndrome is a little bit different. So Sézary syndrome presents as diffuse erythroderma. You can see an example of it here on the top. By definition, Sézary syndrome will have eventually over 80% of the body surface area covered. And it tends to also wax and wane. So at some point it will have over 80%, but it doesn't have to all the time. Other things that you can see here with these patients is keratoderma, which is marked thickening of the layer of the epidermis. You can also see alopecia, which is loss of hair, and hypertrophic nails. Here's an example here of the hypertrophic nails, the thickening. You can also have extracutaneous involvement with Sézary syndrome, which can involve the lymph nodes, the lungs, the GI tract, the spleen, but it actually doesn't often involve the bone marrow. Usually that's pretty rare. Some other things you can see here that I didn't have pictures of is vesicular lesions, purpura, leonine facies, but this is all a little bit more rare. So what is the differential? It can be a lot. There's a lot of things that this can look like, and they can be both malignant and non-malignant causes. So let's go through some examples and clues. So common things being common, if you see these types of things, you could think of things like eczema, psoriasis, parapsoriasis, drug reactions, contact dermatitis. Here, the history is really going to help you a lot. So of course, if you have a trigger, you could think of a contact dermatitis or a drug reaction. One clue is that if someone has eczema and psoriasis and they're getting treated, they're getting topical steroids and it's really not going away, that can maybe make you think of CTCL as well. Other things to think about is that the time to diagnosis for CTCL is often about 5 to 10 years. And that's not because it's bad, it's just because people don't really get to see it. If you give a steroid and it goes away, you just might not catch it at that time. Other things that can look like this, or other things that make you think of CTCL when you see these lesions, is some of the things that we talked about. If you're seeing alopecia, nail changes, skin thickening, that could lead you to think that maybe I should biopsy this, maybe this is cutaneous lymphoma. Another thing that looks like this is erythrodermic psoriasis, but the clue that it's CTCL is that it won't have relative sparing of the face and scattered pustules. CTCL won't. Other mimics for erythroderma, one is pityriasis rubra pilaris. This is a more rare disease that's maybe somewhat related. Scabies or diffuse crusted scabies specifically could look like this type of erythroderma, as well as graft versus host disease and idiopathic hypereosinophilic syndrome. But there, the history is going to help you a lot as well. I also wanted to point out that there are other malignant T cell proliferations. There's even a cutaneous B cell lymphoma. I won't go into details, but just so you guys know, those things exist as well. So what do you do if you think that your patient has cutaneous T cell lymphoma? One point here is that consultation with an expert medical center is highly encouraged. There's not a huge amount of them, but WashU is one of them. Steps you're going to take maybe for every patient, and we'll go over them in detail, are skin biopsy, lymph node biopsy, flow cytometry and immunophenotyping, and next-gen sequencing. So skin biopsy, this is essential to the diagnosis. You're going to want to biopsy the lesion that has the most induration, so kind of the angriest looking lesion, as well as the lesion that's had the least amount of treatment. So if you think back to the patient that had eczema or psoriasis and somebody was giving them topical steroids, you're going to try and want to biopsy the area that's been treated the least, as well as biopsy every area that looks different. So in that patient that had the patches and the plaques and the tumors, you'll want to try and biopsy every area that looks different to you. These are the pathology that you'll see. There's a lot of things to go over, but these are the things that stuck out to me as the most noticeable. At the top, you can see the cerebriform nuclei. This has like the little grooves and kind of looks like a brain. The bottom here, you can see the Pautrier microabscesses. These are the little abscesses that are in the epidermal layer. They're pathognomonic, but they're uncommon. So if you don't see them, that doesn't mean it's not CTCL. Another thing you can see is the lymphocytes aligned in the basal layer here at the bottom. These are these darker cells. They're at the bottom of the epidermal layer. Another thing that I didn't really point out here, but you can see is halo lymphocytes, which are lymphocytes that have vacuoles around them. And another thing to mention here is that for Sézary syndrome, if you're getting a biopsy of the erythroderma, you might not see these features. The next thing you might want to do is a lymph node biopsy. This isn't essential and you might not do it for every patient, but this is if you think the patient has lymph node involvement. And another thing to note for these patients is they could have dermatopathic lymph nodes, which is an increased size of reactive lymph nodes that are usually peripheral, but not necessarily involved. But if you do think you have involvement, you'll want to do an excisional or a core biopsy. Here we do core biopsies and not an FNA. And the reason is because you're looking for how much of the lymph node architecture is effaced by atypical cells. And that's going to help you grade and stage it, as we'll briefly go over in a little bit. And another thing here that I would always think about is, do I need to do a bone marrow biopsy? But no, you don't need to do a bone marrow biopsy because bone marrow involvement is very rare. The next step that can help you make the diagnosis is flow cytometry and immunophenotyping. This would be if you're still trying to make the diagnosis, is this CTCL or is this an inflammatory reactive condition? This can be helpful. So for MF, you're going to see more of a memory T cell phenotype, meaning it's going to be CD4 positive, CD8 negative. CD8 is more of a cytotoxic T cell marker. And early MF lesions can have mature T cell markers, which would be CD2, 3, and 5. And then classically, you'll see CD7 negativity and CD26 negativity, but CD26 is a little bit less specific. CD30, which will also come up in treatment, is another marker that we look at. It's positive about half the time, and usually we see CD30 positivity in Hodgkin's lymphoma and other T-cell lymphomas. Sézary syndrome is a little bit different. The criteria for diagnosis is one of these three that are on the right side of the table. Basically, you just have to have a large population of Sézary cells or a large population of CD4 positive, CD26 negative, or CD4 positive, CD7 negative cells. And the next thing you might want to do, especially if the diagnosis is still unclear, but you might not do this for every patient, is next generation sequencing. And what you're looking for here is gene rearrangements in the TCR or the T cell receptor. And I say that it's not diagnostic because not every patient will necessarily have this, and you might have a clone that is not representing cutaneous lymphoma or is non-malignant. So it doesn't necessarily make the diagnosis. However, a situation in which it could be helpful is if you see an identical clone in the skin and in the blood and in the lymph nodes, then that could help you say that maybe this is more CTCL versus an inflammatory reactive condition. So all this information can help you stage the patient. As we'll go into in a minute, staging is helpful for treatment because we choose the treatment based on the stage. It's actually pretty complicated how to stage these patients, so I'll just do it briefly, but it's TNMB staging. The B is a little bit unique. It's how much blood is involved. The T stage is going to be how much skin is involved, so how much body surface area is covered. The N is the lymph node, so what we talked about a little bit, how much of the lymph node architecture is effaced by atypical cells. M is metastasis, do they have visceral involvement? And B is how much or how many Sézary cells are in their blood, a lot, or none, a lot, or a little bit. The other thing to note here is that in clinical treatment, we always think about the stage, so that'll inform how we treat these patients, but also patients can never change their stage. So it might be a little bit different about how we think about other cancers, like you start with a little bit of cancer and then you end up with a lot of cancer. But for cutaneous lymphoma, a lot of patients stay at the stage that they were diagnosed. So how do we treat these patients? A couple overarching points here is that cutaneous lymphoma is treatable, but not curable with systemic therapy. And most treatment options don't result in a durable remission. So they're given in an ongoing maintenance fashion in order to achieve disease control and not have a huge impact on quality of life. Prognosis is varied and early aggressive therapy does not tend to change outcomes. Considerations you'll want to go through for all of your patients will be disease control versus quality of life, cumulative toxicity, and making sure that you're not forgetting symptom control and supportive care. This kind of all goes to the mantra of don't make the treatment worse than the disease. So now we'll go through a few treatments for early stage. This means less than 2B. And here what I'm talking about is really limited patch and plaque disease. Some we've probably heard of, like steroids. By this, I mean topical steroids. Of course, there's side effects to that, like skin thinning and atrophy, but they're usually well tolerated. There's also nitrogen mustard, which is an alkylating agent. And there's also topical carmustine, which is also an alkylating agent, but that has a little bit more systemic absorption, so it can have more hematologic toxicities. Localized radiation is another one that we can use. We now use electron beam therapy, which means that the radiation really goes into the superficial layer of the skin and it doesn't damage the deeper layer of the dermis. There's also phototherapy. This is not necessarily specific to cutaneous lymphoma, but it can be used. This is UVB and PUVA, which is Psorilan and UVA. This is also usually pretty well tolerated. It can have side effects, but people can do it in clinic. There's also possible to have a home unit, so this is pretty doable. And another one is total skin electron beam therapy. This is a higher dose radiation, and it also has more short and long-term side effects. It does have to be done in a clinic in an academic center. And it can cause things like desquamation, blisters, superinfections, more permanent things like hair loss, finger and toenail loss, chronically dry skin, things like that. Something to note about all of these is that there's not trials of them of efficacy head to head. So like which one is better? When do you add systemic therapy for cutaneous lymphoma? So one reason would be if you have early disease that's refractory to the skin-directed treatments that we just talked about. Another reason would be if you have high-risk features, which would be folliculotropism and large cell transformation. Folliculotropism means that there's follicular invasion of atypical cells in the follicular epithelium. And of course, if you're getting to advanced stage disease, and by that I mean 2B and higher, that's also when you would start thinking about these. And we'll often combine skin therapy and systemic therapy. But the mantra is still the same: don't make the treatment worse than the disease. So you'll want to pick less toxic before more toxic, limit cumulative toxicity, and choose single agent sequentially. So there's a lot, but this is a lot of the treatments for late stage disease, which are systemic treatments. Something to note here is that not all of these are FDA approved, and I'll kind of go through that or mention that as we go through them. And there's only 2 that have been studied in a phase 3 trial, and I'll mention that as well. The first one is actually brentuximab, which is this anti-CD30 drug conjugate. This has been studied in the Alcanza trial, which is a phase 3 clinical trial, and it was compared to methotrexate or bexarotene, and it showed an improved overall response rate and progression-free survival, and it is FDA approved. Bexarotene is an oral retinoid. This can cause hypertriglyceridemia and central hypothyroidism. HDAC inhibitors are another category that is FDA approved. These are histone deacetylase inhibitors. They have side effects as well. They cause GI upset, cytopenias, but they do have clinical activity in all compartments. Methotrexate and pralatrexate are folate antagonists. Most of us have probably heard of those before. Mogamulizumab is the other one that's been studied in a phase 3 clinical trial. This was studied in the Maverick trial, and it was compared to vorinostat, the HDAC inhibitor, and it also showed a higher overall response rate and progression-free survival when compared to vorinostat. But of course, there are side effects: infusion reactions, skin eruptions, diarrhea. The bottom here are some that are not FDA approved. Alemtuzumab is an anti-CD52 monoclonal antibody. This is mainly used in patients that have Sézary syndrome and erythroderma, and it can only be obtained by compassionate use. Pembrolizumab is another one that's not FDA approved. This is an immune checkpoint inhibitor or PD-1 inhibitor. Interestingly, in the study that used this, 40% of patients developed a skin flare reaction, and that was clinically indistinguishable from progression of disease. So that's something to be aware of. Another one that's used for these patients is extracorporeal photopheresis. I had never heard of this before I started learning about it, but it's when you take out the leukocytes from the blood by leukapheresis, you treat them extracorporeally with 8-methoxysorolin, and then you put them back to the patient. So this would be patients that have some blood involvement. The last thing I'll touch on here is bone marrow transplant. Allogeneic bone marrow transplants have been done in this patient population. In systemic and meta-analyses, the pooled progression-free survival and overall survival are 36% and 59% respectively. And of course, there are many side effects and risks to a bone marrow transplant. Auto transplants are not really done in this patient population due to the short duration of response. There's also a couple of more systemic therapies that are more toxic that I didn't mention here, which are gemcitabine and doxorubicin. So this is a unique disease, unique treatments. So these patients have unique challenges. It's highly visible for one. It has a debilitating clinical symptoms like pruritus, pain. We'll go through some more. But our previous work has actually shown that cutaneous lymphoma patients have worse symptoms and worse quality of life, even when compared to patients with similar skin diseases. There's also physical, emotional, and financial stressors. Our previous work has shown that there's a disproportionate financial burden for these patients when compared to how common the disease is. The estimated lifetime cost is about $73,000. And of course, there's also treatment burden, as we talked about in those previous tables. There's lots of side effects, there's frequency to treatment, and there's neuropsychiatric effects of therapy as well. So this all goes to show you that this patient population really has a significant impact on quality of life, or a detrimental impact on quality of life. And improving quality of life on treatment is really important for these patients. So what do I mean when I say debilitating symptoms? This table is from our previous work doing semi-structured interviews with our patient population. And the yellow box is showing you the symptoms that came up the most. So you can see like pain, itch, sleep, skin flaking, skin redness. There's really a long list, but these are the ones that our patients brought up most commonly. Cutaneous lymphoma patients have a worse quality of life when compared to patients with similar skin diseases. This is also from our previous work where we gave the Skindex, which is a metric, a quality of life metric for derm patients specifically to patients, as well as patients with other skin diseases. And here in the yellow box at the top, you can see all stage CTCL scored worse in all domains. The domains are symptoms, emotions, and functioning, and the higher number is a worse score. So you can see pretty significantly that they all had a worse score in all domains. One thing that's not up here, but is also something we found, is that later stage patients have worse quality of life. They scored worse on this. How do we measure quality of life in general? So there's lots of ways to measure quality of life that already exist. They're all surveys or metrics. What I mentioned is Skindex, but they can loosely be categorized into general, dermatology focused, cancer focused, and there's actually a MFSS CTCL one that's specific to cutaneous lymphoma. However, current measures are not sufficient. This is also from our previous work doing semi-structured interviews with our patients. And you can see here at the top that there's a few examples of the quality of life metrics that already exist. And the yellow boxes are meant to show you that there's big chunks of domains that are missing. So the domains on the side are the ones that our patients brought up as being important to their quality of life. And really none of these that already exist will cover some of these main domains that kept coming up. Important ones are sleep, skin breaks, skin flaking, lack of understanding in the community, and a feeling of otherness. And even in the MFSS specific one in the red box, you can see that there's really tons of missing domains in that one too. So it's missing the same domains that all the other ones are missing. The other issue with the MFSS quality of life survey that exists already is that they didn't use late stage patients in order to make this survey, and we know they have a worse quality of life. So what's coming up for us is creating a new quality of life metric. Now that we know that this is really important to this patient population, we're trying to make a survey that's both comprehensive and disease specific. So we're kind of at between stage 1 and 2 right now. We developed a new survey with new items that are coming from both our early stage and late stage patients. Next, we're going to conduct cognitive interviews with a small cohort of patients. This will tell us, is the wording okay? We need to fine tune the wording. Is it confusing? Do our patients know what we're asking? Next, we'll run a principal components analysis. This will help tell us if our questions are telling us what we want them to tell us. Are there redundant questions? Are there questions that are not really finding a difference between people with worse or better quality of life? Are there ones that don't tell us what we think they should tell us? So that'll help us cut down the survey. And finally, we'll evaluate convergent and discriminant validity of this survey, which basically means, does our survey perform as well as other already validated surveys? For example, does it evaluate depression as well as an already validated depression screen? With that, we're hoping that we can actually have a metric that works well for this patient population, and we can continue to monitor their quality of life while they're on treatment. And with that, I'll wrap up. Huge thank you to my mentor, Dr. Neha Shah, as well as the mentors for this project, Dr. Musiak and Dr. Jesse. And of course, WashU Internal Medicine and our program director, Dr. Costco, and sources of funding, C-STAR MIM and the Cutaneous Lymphoma Foundation. Thank you.
Thank you, Neha. That was truly wonderful. We'll now head over to Dr. Margery Gang. Margery is a native of Novi, Michigan. She then came to St. Louis for both undergraduate and medical school. She was an English and biochemistry major. And then in medical school, she was a Howard Hughes Institute Medical Research Fellow, having received funding and mentorship for her work with NK cell immunotherapies, and completed her master's degree while doing so. She's now also completing her internal medicine residency with the C-STAR research program. And she is also applying to hematology oncology and would like to focus on hematologic malignancies. So please welcome Dr. Margery Gang.
Hi guys, I'm Margery. It's nice to meet you all. So today I'm going to talk about CAR T cell therapy and how we can engineer the immune system to fight cancer. So cancer truly is the emperor of all maladies. Over the past few decades, there's been an increasing incidence of cancers. And this graph from the CDC shows that from 1990s to 2019, the annual number of new cancer diagnoses. And in 2019, there are 1.8 million new cancer diagnoses that were reported in the US. So not only is cancer incidence increasing, but it's also a major cause of mortality. And in mortality data compiled nationwide, cancer remains the second leading cause of death in the United States, with an estimated 1 in every 4 deaths due to cancer. And in provisional data from 2020, amid the pandemic, more patients actually died from cancer than COVID-19. And so unfortunately, taking care of a cancer patient remains important for every doctor. So today I want to talk about immunotherapy as a new pillar of cancer care, provide an overview of adoptive cell therapy, or ACT, describe chimeric antigen receptor T cells, or CAR Ts, their modularity, current applications, as well as adverse side effects, and then talk about what's next in CAR therapy, off switches, different vehicles, and applications outside of cancer. So to begin, let's start with chemotherapy. And chemotherapy interferes with cellular division and induces DNA damage to cause cell death. But chemotherapy is systemic, it's not very specific, and it really leverages the fact that cancer cells divide much more rapidly than your normal cells. But this is also why some patients experience, they lose their rapidly dividing cells in their body, their hair, their oral mucosa, their skin. And unfortunately, the immune system is also rapidly dividing, and chemo can cause neutropenia, which exposes these patients to increased infection risks. So in contrast to chemo, which acts directly on rapidly dividing cells, immunotherapy acts on the host's immune system. Now, normally these cancer cells can put up defenses to hide against our immune system. They can secrete these immunosuppressive cytokines. They can suppress the MHC class I self-ligand expression to avoid T cell surveillance. And they also can increase the expression of inhibitory ligands like PD-L1, or programmed death ligand 1, to inhibit cytotoxic T cell killing. Thus, the goal of immunotherapy is to reactivate our body's immune system to recognize and kill tumors. And because of this, it's become another pillar of cancer care alongside surgery, radiation, and chemo. And there are several different methods of delivery. There are cancer vaccines, antibody drug conjugate systems that target drug delivery, as well as cytokines that activate our immune system. There's also checkpoint blockade therapy that prevents the binding of these inhibitory ligands like PD-L1 and CTLA4. And then finally, there are cell-based therapies, which includes CAR Ts, which I'm going to talk about today. So before we talk about CARs, let's kind of go back and give some historical context. Prior to the advent of bone marrow transplants, the median survival times from diagnosis was about 5 to 7 months for leukemias. And the first successful bone marrow transplant was done in 1956 by Dr. Don Thomas in New York, where the bone marrow was taken from a healthy identical twin and given to the other twin who had leukemia. And in 1990, Dr. Thomas was awarded the Nobel Prize because his work in the bone marrow transplant ended up curing around 40% of patients undergoing allogeneic transplant. And so the use of transplant has now been later expanded to treat other hematologic diseases, including myelodysplasia, non-Hodgkin's lymphoma, and thalassemias. And significantly, in Dr. Thomas's work, he also observed that T cells were the crucial mediators of allogeneic allograft rejection, as well as graft versus leukemia effects. And with that, evidence that the immune system can actually eradicate cancer. And his work provided the impetus for subsequent research into developing cell-based immunotherapies. And currently, the long-term survival for leukemia patients receiving transplant are excellent. 80 to 90% of 2-year survivors end up surviving 10 years. So while transplant is often a life-saving treatment for some patients, it's associated with high treatment-associated mortality. There's graft versus host disease, which is an inflammatory condition where after allotransplant, the donated T cells view the host's body as foreign and attacks the skin, intestine, and liver. And this can even happen if the donor and recipient are HLA identical, and it requires treatment with high-dose corticosteroids. Because the recipient's bone marrow is ablated to allow for a transplant, these patients can experience prolonged immunodeficiencies that may persist. And in addition, the immunosuppressive regimens that are needed to treat or even prevent graft versus host further increases the risk for opportunistic infections. Patients can experience severe liver injury from hepatic veno-occlusive disease, which is also called sinusoidal obstructive syndrome. And unfortunately, these patients can also have cancer relapse, which accounts for the most frequent cause of treatment failure after allotransplant. And they also have increased incidence ratios of secondary cancers, including bone, head and neck, and melanoma. So while post-transplant outcomes have continued to improve throughout time, this remains a highly morbid treatment. So the next question arises, if our immune system is naturally able to eradicate and kill cancer cells, how can you pull out a T cell and convince it or reteach it to attack the cancer without attacking our own body? So let's talk about CARs. On the left, I have a T cell receptor, and the T cell receptor recognizes foreign peptides bound to MHC proteins on antigen-presenting cells. And this will prime the T cell and activate the T cell through the intracellular domains and allow them to kill their tumor target. Chimeric antigen receptors are so named because they're truly are a receptor made up of different parts. They're part T cell and part B cell, much in the same way that the mythologic fire-breathing chimera is made up of a lion's head, a goat's body, and a serpent's tail. So CARs have this extracellular antigen binding domain, and the CAR specificity is actually determined by the antigen binding single chain variable fragment, or SCFV, which has fragments made up of the variable heavy and variable light chains of an antibody. And it's fused via a hinge and transmembrane domain to the intracellular signaling domains. And this includes T cell receptor CD3 zeta chain, as well as additional costimulatory domains like CD28 and 41BB. So when CAR Ts see and bind to their tumor-associated antigen, they become super activated. They divide and proliferate by the millions and induce tumor cell death. And this ability to expand and proliferate in vivo truly means that CAR Ts are a living drug, with studies showing that CAR Ts can persist in patients and continue cancer surveillance for years after a single infusion. So adoptive cell therapy with CAR Ts represent a major advance in the fields of cell therapy and personalized medicine. And in this strategy, a patient's own T cells are isolated from the peripheral blood. They're genetically modified to express this CAR targeted towards their cancer. These CARs are expanded ex vivo in the lab and then reinfused into the patient to treat their disease. So the first patient to ever receive a CAR T was Bill Ludwig. And Bill had refractory p53 deficient chronic lymphocytic leukemia, or CLL. And he had progressive leukocytosis and adenopathy despite numerous treatments. And CLL is the most common form of B-cell leukemia in adults in Western countries. And it's a chronic disease. And unfortunately, most patients with CLL end up relapsing within the first 5 years of receiving first-line treatment with chemoimmunotherapy. So in June of 2010, Bill was the first patient enrolled in a clinical trial to receive a CD19 CAR T targeted towards a CLL, but was later known as Chimera. And this is a picture of Bill and his wife with Dr. Carl June on his right and Dr. Levine on the left, the co-inventors of Chimera. So after the CD19 CAR T infusion, Bill had no evidence of CLL in his bone marrow by morphologic, karyotypic, or flow cytometric analysis. And the researchers were actually so astonished by this result that they had to repeat the bone marrow biopsy on the other side because they just didn't believe it. His adenopathy had also completely melted away on both physical exam and imaging. And Bill ended up having a sustained decade-long remission of his CLL after CAR T therapy. Unfortunately, he did pass away last year in January of 2021, not from his cancer, but actually from COVID-19. So currently, there are 6 FDA-approved CAR T cells on the market. The first one is Chimera, which I talked about, and this is approved for patients with relapsed or refractory diffuse large B-cell lymphoma or young adults with relapsed or refractory ALL. There's Yescarta and Breyanzi, which are a second or third line for B-cell lymphomas. There's Tecartus, which is approved for mantle cell lymphomas and ALL. And more recently, there have been approvals for Carvykti and Abecma, which target BCMA for multiple myeloma. So CAR Ts have really changed the therapeutic landscape for cancer. And here I have 2 studies side by side, separated only by time. And on the left, I have Scholar 1, which was a retrospective study done in 2017. And on the right, I have Zuma 7, which is a 2022 phase 3 trial looking at CAR T cells. So prior to CAR T, the outcomes of patients who failed first-line treatment for diffuse large B-cell lymphoma were horrible. And in this retrospective study, Scholar 1, they found that the median complete response rate to standard of care salvage therapy was 7%. And these patients had very poor prognosis with a median overall survival of 6 months. Zuma 7 was a recent phase 3 trial looking at CD19 CAR T therapy compared to standard of care salvage therapy. And their primary endpoint was event-free survival, which included disease progression, needing to start a new therapy for lymphoma, or death from any cause. And the median complete response rate that they saw was 65% for CAR Ts versus 32% in standard of care, so twice that. And the median event-free survival rate was greater than 8 months for CAR Ts and only 2 months for the standard of care arm. So unfortunately, CAR T therapy, while it's been amazing for these patients, is not without severe adverse side effects. And one of the most frequent adverse side effect is called cytokine release syndrome, or CRS. And CRS is this acute systemic inflammatory syndrome that's characterized by elevated levels of cytokines, including IL-6 and interferon gamma. And this occurs in about 80 to 90% of patients. CRS can present as a wide variety of symptoms, ranging from a mild flu-like disease to severe life-threatening disease. It can be shock requiring vasopressors, ARDS, DIC, and multi-organ system failure. And patients can also experience immune effector cell-associated neurotoxicity syndrome, or ICANS. And ICANS can occur with CRS, after resolution of CRS, or even in the complete absence of CRS. And ICANS is characterized by anything from inattention, altered mental status, seizures, or cerebral edema. And the underlying pathophysiology of ICANS is very poorly understood, but it's thought to be related to cytokine-mediated endothelial activation, resulting in compromise of the blood-brain barrier, resulting in cytokines in the CSF and brain parenchyma. And both of these syndromes often require ICU-level care. And these can be treated with tocilizumab, which is an anti-IL-6 receptor antibody, and or systemic corticosteroids to dampen the immune cell activation. So in addition, another known side effect of CAR therapy is called on-target off-tumor. So the ideal target antigen is restricted to the tumor cell. And CD19 is a perfect example of this because it is only expressed on B cells, and a patient's B cell population can be completely eradicated without many side effects to the patient. Occasionally, they'll need immunoglobulin infusions. Unfortunately, most tumor antigens are also expressed in some form on normal tissues. And this shared expression on normal tissues in the tumor result in some degree of on-target off-tumor effects. And in a 2010 study, a HER2 positive colon cancer patient with metastatic disease was treated with an anti-HER2 CAR T cell. Unfortunately, she developed rapid respiratory failure within 15 minutes of receiving a single infusion, had multiple cardiac arrests, and subsequently died. And when they looked at her serum after treatment, they saw that 4 hours after treatment, she had 1,000-fold increases in her inflammatory cytokines. And HER2 is not a tumor-specific antigen, and it's normally found in epithelial cells in your GI and respiratory tract, as well as in your normal hematopoietic cells. And so the cause of death for this patient was actually attributed to the low levels of HER2 that were expressed in the epithelial cells of her lung, which were attacked then by her CAR. So let's talk about CAR safety. What if we can switch CAR Ts on and off to stop immune cell overactivation? If a patient has CRS, we can just stop the CAR T without exposing the patient to steroids, which inhibits the patient's own immune system. So in one method, we can utilize a small molecule bioinert chemical induction of dimerization, also called a CID. And giving this CID allows dimerization of this inducible safety switch caspase-9. And this activates downstream signaling cascades and results in targeted apoptosis of CAR T cells while allowing the rest of your immune cells to survive. So other labs have also made CAR T cells with off switches controlled by other drugs, including ganciclovir through an HSV thymidine kinase. And use of these off switches has been integral to improving the safety profile of CAR Ts without compromising the host's immune system. The use of CAR Ts in solid tumors has also been pretty limited. The tumor microenvironment in solid tumors provides a unique challenge in CAR trafficking, infiltrating, and proliferation and survival. The tumor microenvironment is very hypoxic, it's acidic, there's no nutrients in there. And so these tumor cells also will upregulate inhibitory ligands like PD-L1. They'll secrete these immunosuppressive cytokines like IL-10 and TGF-beta, and this will cause T cell exhaustion and apoptosis. So the idea of armoring the CARs to protect against this immunosuppressive tumor microenvironment came up. So in one method, we have trucks, or T cells redirected towards universal cytokine killing. And trucks constitutively express and secrete cytokines like IL-12, 15, or 18 that are activating, and this will help the CAR T overcome the immunosuppressive environment of the solid tumor. There are also cytokine modulating CARs, and these are CARs that have co-expression with decoy receptors that will bind the immunosuppressive cytokine and prevent them from acting on the CAR T and inducing downstream signaling. And finally, there are antibody secreting CARs that also will secrete checkpoint inhibitors like anti-PD-1 scFvs to block immune checkpoint signaling. Recent work has also looked at utilizing other immune cells as vehicles for CARs, including NK cells, regulatory T cells, macrophages, dendritic cells. And in the interest of time, I will just talk about CAR NKs because this is a huge field. So NK cells, these are CD3 negative, CD56 positive innate lymphoid cells that play a fundamental role in host defense against viruses and tumor cells. And unlike T cells, which require priming with antigen-presenting cells, NK cells can directly kill the tumor without prior antigen priming. And whereas T cells have a single dominant T cell receptor binding that regulates T cell activation, NK cells have these broad repertoire of both activating and inhibitory receptors, and it requires a complex integration and balancing of these positive and negative signals to determine whether or not an NK cell kills or does not kill a cell. And when tumor cells downregulate their MHC class I molecule or their self-ligand to escape T cell killing, these cells are still susceptible to NK cell killing through the missing self mechanism, where NK cells will recognize the lack of MHC class I. And finally, while the adaptive transfer of T cells have side effects like graft versus host or CRS, adaptive transfer of NK cells have not been shown to have any graft versus host or CRS. So this is a recent phase 1, phase 2 study that was done by the Resvani lab at MD Anderson, which shows CAR-NK therapy. And so they developed CD19 CAR-NK in patients with relapsed and refractory CD19 positive cancers. They had 11 patients that they recruited and gave one of 3 escalating doses. So among these 11 patients, remarkably, a majority had a response to treatment with CAR-NKs, and 7 ended up having complete remission. The administration of CAR-NKs in this study was not associated with development of cytokine release syndrome, neurotoxicity, or graft versus host disease. And they also noted that there was no increase in the inflammatory cytokine profile in these patients, including IL-6, as well as TNF-alpha compared to baseline. And these CAR-NKs persisted in these patients for at least 12 months after infusion. I do want to talk about my work in Todd Feniger's lab here at WashU. So Dr. Feniger's lab has looked at cytokine-induced memory-like NK cells in relapsed and refractory leukemias. And these memory-like NK cells will differentiate after being activated with IL-12, 15, and 18, and they already exhibit potent anti-tumor responses against in patients with leukemia. So we hypothesized that the memory-like differentiation and CAR engineering together would result in complementary improvements in NK responses against NK-resistant cancers. So we developed these CAR memory-like NK cells, which we called caramel NKs against CD19. And we found that these caramel NKs had increased interferon gamma production, degranulation, and specific killing in vivo. Here we have our mouse model where we looked at our caramel 19 in a mouse model that was given a CD19 positive tumor. And we had 3 arms, CD19 positive tumor only, a mouse that was given tumor with our CD19 targeted caramel NK, as well as a mouse that had tumor and a non-specific off-target caramel NK. So what we found is that when we treated these mice with CD19 caramel, we were able to significantly decrease lymphoma burden, and it also had these mice had increased survival when we compared it to caramels that had an off-target scFv. And while I spent the last 20 minutes talking about cancer, CARs aren't just for cancer. Recently, a group at the Perelman School of Medicine in Philly developed CAR T cells that have targeted fibroblast activating protein, or FAP, to specifically eliminate activated fibroblasts as a therapy for heart failure. And in mouse models, they were able to show that CAR Ts could express this FAP CAR in vivo, and this anti-fibrotic CAR could actually reduce fibrosis when compared to placebo, and this restored cardiac function after injury. So we are only going to see more applications of CARs in the upcoming years. Currently, CAR Ts therapies account for more than half of all the trials for hematologic malignancies. And this is a screenshot that I took from clinicaltrials.gov just a couple of days ago, which shows 1,700 active studies looking at CAR Ts in various diseases. So this morning, I've had the opportunity to give you a brief overview of the past and present of cell-based therapies. But what I'm really most excited about is the future. I think CAR therapies will continue to become safer as we develop better on-off switches to have CAR Ts only become active when they see cancer and also turn off to prevent side effects. The vehicles that express CARs is only going to continue to broaden. And research is looking into developing an off-the-shelf CAR, which doesn't require getting T cells from an individual patient to treat their own cancer. And this would decrease the manufacturing time as well as decrease costs. And what we can use CARs for is will also only continue to expand, from heart failure to infectious diseases to autoimmune diseases, and possibly even neurodegenerative diseases in the future. So what we see now is really only the beginning of what CARs can do. I'd like to provide my thanks to everybody here, Dr. Costco, the Chiefs, Wisdom House staff. I'd like to thank Dr. Todd Feniger and the TAF Labs for supporting me during my HHMI year. I'd like to thank my mentors here with C-STAR, Dr. Lee Ratner, Dr. Thomas, as well as Dr. Gage. And finally, I'd like to provide a thanks to my fiance, Robert Chen, who's in the audience today, as well as Suzuki, who listened to me practice this talk many, many times last night. This is my works cited, and I will open for questions.
So thank you, Margery, Neha. These are wonderful talks. We have a few moments for questions. If anyone here in the audience has any questions for either Margery or Neha, and we'll also check in on the chat in case anyone there has any questions. You're welcome to submit them via Zoom.
So this is for Neha. Thank you for the talk today. I did have one question or comment about the principal component analysis you proposed. So PCA belongs to a family of analyses called independent component analysis. And one assumption in that is that every component is independent. Or so with your proposal to look at the sensitivity of your questions for quality of life, I'm worried that like patients' answers aren't necessarily independent to each other, and so that your PCA won't necessarily be able to clean this data. So I'm wondering if you might have, there may be like better sensitivity analyses or like feature importance that would really show you which questions are like most important to the quality of life metric.
Yeah, can you hear me? This is loud enough. Yeah, I thought about that too. I think what's also, it's like, I'm gonna have to rethink it. I think also when we do the cognitive interviews, because I think what I don't know yet is if that's gonna eliminate some questions too. Because right now our survey is 46 questions. So I think like it's sort of kind of have to be like a step-by-step, like reanalyze it, because I think if I have way less questions than I think when I get to the principal components analysis, that would change things too. So yeah, I agree with you. I think that is a concern too, but also I'll be honest, the principal components analysis is also being done by Dr. Jeffy, who's like much more specialized in this type of thing. Yeah, that's my answer. Thanks.
Okay, well, thank you, everybody. Again, thank you, Neha and Margery. I mean, what amazing careers already just having started. So we greatly appreciate your talks today, and we'll be back here same time next week for 2 more senior resident talks, and we will ensure that we have food. I apologize for the bagel situation. It'll be back twice as good next week. Thank you.